We'll get started. Session 5, Shock and Cardiac ICU. My name is Dr. Nathan and this is Dr. O'Neill. Nobody needs to introduction for him. We'll be the moderators for this session. As a reminder, we have a lot of speakers and 7-minute time and audience response 7 minutes. So we got to finish this meeting at 12. So please be kind enough in trying to get this in a timely manner. Act 2, we're going to start off with a debate. Should cardiac arrest be included in cardiogenic shock staging? We have Dr. David Baran for.
Thank you. I appreciate the invitation and my apologies to my opponent Maya for what's about to happen. So should cardiac arrest be included into cardiogenic shock? This is like a softball. The answer is clearly yes. Here's my disclosures. This is a very simple question. Should cardiac arrest be involved and included in cardiogenic shock? Well, does one occur without the other? Does treatment of one affect the other? Does a different treatment team treat each? Or do you have robust data on the coexistence of both? Well, we'll tackle these. And I would say, like these things you can see in those who are not in the United States, the bottom right is what we call a s'more, American creation, sells a lot of graham crackers, probably the only good thing they're good for. Of course, shock and cardiac arrest go together. Does one occur without another? Well, certainly some people get cardiogenic shock and don't have a cardiac arrest. However, if the heart stops, it's not a big leap of faith to say that bad things happen, and of course the patient's going to develop cardiogenic shock. A key differentiator is the neurostatus. There's quite a difference between the patient who has a single shock and is sort of ticked off at you because you shocked them out of it and they're cursing at you and they're awake and they're neurologically fine, or the person that has a cardiac arrest and is obtunded. The problem, however, is like the brain. The brain is a really squishy thing. You see a nice one here in a bottle. It's like a black box. It's very hard to interrogate it. You don't really have any good prognostic test. How many of us have been to the bedside and the family says, is John going to wake up? I don't know if John's going to wake up. I have no way to tell. If he wakes up, that's good. If he doesn't, I'm not so sure. So how can we study cardiogenic shock without looking at cardiac arrest? And there's lots of different things intensivists say they know how to manage it. If a patient has a cardiac arrest, we'll go ahead and cool them, we'll keep them warm, we'll keep them in the middle, who knows what. None of it actually works. This is a paper about 3 weeks ago looking at the duration of device-based fever prevention. Another way of saying targeted temperature management, or don't let them have shivers. And if you look at the editorial in the bottom right, the bottom line is mortality is awful either way. And it doesn't matter what you do with temperature. That, unfortunately, was an abysmal failure. Does the treatment of cardiac arrest affect cardiogenic shock? As I said, unfortunately, when you do targeted temperature management of any kind, you really set yourself way behind. The patient is then, for 2 to 3 days, unable to respond. You have to paralyze them, you have to sedate them, you have coagulation issues, you have hemodynamic disturbances, all these things. You've made your life infinitely more complicated and you haven't actually helped, and no data actually shows that it really preserves other than anecdotal evidence. Remember that cardiogenic shock is not a static process and the patients often deteriorate, but if you have 2 to 3 days, you can't be sure if the head is awake or not. That's a big, big problem. You keep your patient locked in the igloo. What good does that do? Meanwhile, your ICU bed is blocked. You're not sure if there's actually a live patient in there or not. As I said, the brain is a black box. What about refractory cardiac arrest with ECLS? So obviously, Dr. Yiannopoulos and his team, the only ones to actually show in their microcosm in Minneapolis, clearly works on. On the right is the neurologic status, and it shows actually that the patients tend to improve over time. So if you're in Minneapolis, that's quite good. If you're in the rest of the world, like the beautiful presentation yesterday from Netherlands, maybe not so much. But the point being, at the extremes, cardiac arrest and cardiogenic shock are linked together. The treatment of one affects the other. They are on the spectrum. It's like trying to separate 2 pieces of DNA. Maybe that works if you're developing a vaccine, but in the clinic, you can't really separate cardiac arrest and cardiogenic shock, can you, Maya? How about this? Does a different treatment team exist? Well, let's see. If you look at there, it shows you the people on the cardiogenic shock team, the intensivists, the surgeons, the nursing, palliative care, pharmacy, and wow, surprise, the people who treat cardiac arrest are the exact same people. These patients travel together, so no, we don't have differences there either. What about the data on the coexistence of cardiogenic shock and cardiac arrest? Well, this is a paper I was privileged to work on with Dr. Henry and colleagues. And the reality is, unfortunately, we do a lousy job. We love to show if they live or die. That's always the punchline towards the right. But as you go towards the left, about 50% of the time we have something as simple as lactate. And then to the far left, we forget to report if the patients are awake or not, the Glasgow coma score. Unfortunately, so because of that, we have all these studies, and it shows you more than 2,000 patients that have been studied in shock, but the majority of them, you don't have any data on the neurologic outcomes. You know that neurologic outcomes are bad, but gee, we got to do a better job of studying shock and reporting it, and then reporting what happens to the brain. So cardiac arrest, the neurostatus has to be reported. It's one of these dull moments. How in the heck do we forget that? Well, so problem with this is that trials in general don't enroll real-world patients either. This is actually a nice paper by Schrag et al., including Holger Thiel, and they took a large registry in Germany showing you that if you look at the danger shock, ECLS shock, Euroshock, actually even if every single patient were consent affirmative, in fact only a quarter of patients would actually get into trials. So unfortunately I don't know that we're going to get the answer because we don't even enroll the patients. One of the small trials that did enroll sick patients, many are very familiar with IMPRESS-CP, 48 patients, Impella versus balloon pump, and the patients were terribly ill. This was really trying to raise the dead. In fact, patients who most of them had an arrest. In fact, if you could consent for the trial, you couldn't get in. You had to be on the ventilator. So really, really sick, majority on the dreaded hypothermia. And reality is it didn't affect survival at all. But why? Because a lot of these people woke up without a brain, and therefore they didn't go home. Well, you could say, well, of course, Impella is not enough. ECMO is the answer. Well, a few weeks ago, ECMO CS trial in circulation. Damn it, ECMO is not the answer either. They all die. Okay, how about if we combine two failed interventions? Let's combine ECMO and Impella. That ought to work. Well, that sounds really good, except that doesn't work either. There's a marginal difference between the lines, but if you look, it comes at a huge price. Perhaps in combining two devices might be a little tiny bit better. Look at how they cross the one line. A little bit better for ECMella, but bleeding is worse. So in summary, cardiac arrest and cardiogenic shock, gosh, they go together. We must report better on both of them together. Any attempt to separate them is misguided, futile, and doomed to failure, and they're linked by all of the things you see here. So they're linked by presentation, treating teams, therapies, outcomes, and trials. You cannot separate them. Thank you.
Thank you, David.